Okay, great. Today I'm going to lecture to you about the evidence for hip surveillance in children with CP. As is our custom, I wanted to tell you I have no disclosures, financial or otherwise. So the talk today is going to be about normal development. We'll start with that, and then I'll go over the pathoanatomy of neuromuscular hip dysplasia, talk to you about the evidence for hip surveillance programs, and finally I'll touch upon some application of hip surveillance in California, and at least the group here seems to be pretty far along with that already, so I'll give you some ideas, but I think you guys have things under control. So let's start with some hip vocabulary. The acetabulum is the socket. The femur has the ball and the thigh bone. Obviously, I'm speaking to a pretty sophisticated crowd, but the further anatomy is that we have the capital femoral epiphysis, which is the ossific nucleus of the proximal femur, and then the greater trochanteric apophysis is another growth center that shows up in early life. Some of the soft tissues that are important, the labrum and the capsule, are not seen on X-ray, but form important parts of the structure of the hip. And the triradiate cartilage is the acetabular growth center that I'll talk about in detail in a moment. And the proximal femoral physis, as you see here, is a growth center that traverses along the entire femoral neck and proximal femur, and eventually promotes both the longitudinal growth of the femoral neck as well as the width. So embryonic limb development is kind of where we should begin. And you can see that at 4 weeks, the limb buds begin to form, and that's due to protein morphogens that are determining the formation of the limb both in the proximal distal as well as the dorsal ventral axes. So it's a complicated set of pathways that go on to then form a femoral head and acetabulum by 6 weeks. By 8 weeks, the hip labrum, ligaments, joint capsule, and synovium are identifiable. And amazingly, by 16 weeks, the hip joint space is completely formed. And at this point, the muscle structures are mature, and you're starting to see active motion. You can see here on either side of the femoral head are blood vessels that are starting to go in, which will then start the formation of that capital ossific nucleus. The growth of the hip happens through two major mechanisms. The first is interstitial growth, which is growth from the actual growth plates here with the red arrows of the proximal femoral physis as well as the triradiate cartilage. And then appositional growth is growth from the periosteum or the cartilage, which is also another important mechanism for the width and shape of the proximal femur. In terms of acetabular development, the depth and morphology is primarily determined by the triradiate cartilage. And that depth and shape is really determined by age 8. So that's kind of our landmark for when, at least in terms of changing the shape of the acetabulum, we try to make our interventions before that time. Interstitial growth via the triradiate cartilage occurs, as well as appositional growth via the articular cartilage. So we usually think of the articular cartilage as sort of a passive entity that sort of lubricates the joint and that sort of thing. But in a growing child, there's active development of actual hip shape by this articular cartilage. And I'll show that to you in the subsequent slides. So the triradiate cartilage continues to grow until puberty, and premature closure is relatively rare. And you can see here in this diagram below that premature closure leads to an appearance of subluxation of the hip, but that's largely due to acetabular cartilage growth that is hypertrophied or overgrown. But the most important determinant in normal development of the hip is concentric location of the femoral head in the acetabulum. That is, the center of rotation of the femoral head and the center of the arc of the acetabulum are one and the same. So if you start to have femoral subluxation, as you can see on the middle diagram, the articular cartilage begins to hypertrophy to fill in the space. So although on the X-ray it appears that there's nothing there, the articular cartilage is actually filling up the space over time. And when you get a case of femoral dislocation, you can see that there's dramatic articular cartilage hypertrophy so that it's obliterating the potential space for the hip to go back in, which is why as neuromuscular hip dysplasia is progressive, if you don't act within 1 or 2 years, the ability to obtain a reliable reduction with surgery is out the door. It's really impossible. So let's get into the pathoanatomy of neuromuscular hip dysplasia. So neuromuscular hip dysplasia should be distinguished from developmental dysplasia of the hip. And I want to highlight to you the predominant difference. In neuromuscular hip dysplasia, you have a normal hip at birth. That's important because the displacement is progressive over time due to the muscular imbalance as well as the delayed ability of the skeleton to remodel to what would be normal ambulatory forces. So you have continued fetal positioning of the proximal femur, and I'll describe that to you in a moment. In developmental hip dysplasia, however, these children are neurologically normal, but the abnormality lies in the ligamentous ligamentous structures and laxity of the hip itself, so that you have capsular laxity causing excessive motion. And the reason why you get the later problems with hip development is that the femoral head is really abnormally positioned from birth. So although both of these processes lead to pathologic hip formation, they happen via very different mechanisms. And that's important because the lessons that we take from treatment of developmental dysplasia of the hip don't necessarily translate over to neuromuscular hip dysplasia and vice versa. So in neuromuscular hip dysplasia, we have progressive displacement over time. So the displacement is slow and it's silent. So that is, as we're looking at these x-rays over the course of 2 years, if we had interim x-rays, we would see that this left hip was dislocating by a slowly increasing migration percentage. And so it's very important for us to identify this early before their symptoms. So as physical and occupational therapists and medical providers in the room, you know that hip dysplasia doesn't happen in a vacuum, that there's physical changes that you see. And so the highest risk patients that we see, or the highest risk children, are those that are having progressive changes on their physical exam. And the things that you will see as therapists are hip adduction and flexion contractures. You'll see increased adductor spasticity. You'll see an apparent limb length difference, sometimes due to a windswept or oblique pelvis. Other times it will be to actual limb length difference due to a hip dislocation or a subluxation. You might see a windswept deformity where one hip is adducted and the other is abducted, and that even the abducted hip actually has a contracture in the opposite direction where you can't bring it to neutral. And finally, scoliosis is also can lead to pelvic obliquity and other problems. And in some of the more involved children, that's also an issue. So you all are really the first responders in a very big way in identifying these changes in physical exam that are going along with the changes on X-ray. So the detection strategy then really depends on the cause. In neuromuscular hip dysplasia, because we have a normal hip at birth that is progressively displacing, surveillance is the strategy, in that every child gets checked at multiple points, depending upon their risk of developing hip dysplasia. In developmental dysplasia of the hip, there are criteria that put a child at risk, and those children get a single study, a screening study, usually an ultrasound, to see if there's abnormality. If there's no abnormality, they're discharged. It's done. And so it's a very different strategy in neuromuscular hip dysplasia than in developmental dysplasia. So the key to all of these surveillance programs is an assessment of risk. And all of you are familiar with the gross motor function classification system, I hope. For those of you who aren't, I'll just go over some salient points about the GMFCS system. So it is based on levels that describe the patient's ability to initiate and perform gross motor function, and it is not related to topographic involvement. And that was a real innovation in understanding and describing CP, because up until then, we were really stuck with the topographic descriptions. And so a child who was quadriplegic may actually be ambulatory, but just has all 4 limbs involved. But that didn't really describe the level to which their motor development was delayed or was different. What's very important, though, is that the descriptors in each of the GMFCS classifications are different for different age bands. And the most, and that's important because all of the pictures that you see, like these pictures, are actually from the age 6 to 12 age band. And so as most of you know in the room, the descriptors will go along with the child's development over time, because it would be, in some ways, sort of ridiculous to have a system that said you were either ambulatory or non-ambulatory, because every child would then start off non-ambulatory and become ambulatory, right? So the whole point of the GMFCS is that the classification stays constant over time. So it's describing the child's delayed motor developments as you get to more severe levels. So the GMFCS classification really was a series of descriptors that made sense to a trained individual, but I would argue to you that the pictures revolutionized our ability to communicate. And we really owe a debt of gratitude to the group in Australia who created these very visually pleasing pictures of each of the children at the age at which most interventions occur, which is between age 6 to 12. For ambulatory children, it's the single event multi-level surgeries are happening at this age. Many of the children who in the higher GMFCS categories are undergoing more treatments at this age. And so they really helped us in a big way by simplifying our communication. So just as a review, GMFCS1 walks without, at age 6 to 12, walks without any support and can run and jump. GMFCS level 2 starts to use handheld support for stairs, but has limited ability to jump and run. By GMFCS 3, you're using a handheld device for walking and wheeled mobility for long distances. GMFCS 4 are using self-directed powered mobility, and sometimes we'll use a body support walker. And by GMFCS 5, most of these children have limited head or trunk control and require full support for mobility. You'll notice that at least one of the images has changed over time for the GMFCS 5 to be more sensitive to the way that these children are actually propped, sitting in their wheelchairs. Well, the GMFCS system began as a system to describe gross motor function, but because it is so reliable and is such a good way to describe children with CP, it has been applied to multiple different domains, including hip displacement. And you can see here a nearly stepwise increase in the risk of hip displacement as your GMFCS classification goes up. So the GMFCS1s have a very low risk. In this study from Australia that was a population-based study, there were no children in the GMFCS1 category who had hip displacement. But because the GMFCS level descriptors are fluid over time, even the best children, best walkers among us, among our population, still deserve a clinical exam, which is why all of the hip surveillance guidelines still perform a clinical exam even at the GMFCS1 level. So although your group is referring children to Dr. Lalonde for further evaluation, I would argue to you that because 1 in 3 children have a risk of hip displacement, every child with CP should be under hip surveillance. And that does not necessarily mean x-rays, but it means clinical exams that all of you are doing as part of your standard assessments. And then for the higher risk children, risk stratified x-rays. So untreated hip dysplasia looks very different in ambulatory versus non-ambulatory children. In ambulatory children, hip subluxation is really the standard, so to speak. Hip dislocation is very unusual, but subluxation is relatively common in those that develop it. And it's those children with dense hemiplegia, as you heard earlier from Kristen, that have the highest risk of developing this hip subluxation. I'll talk about that group in a moment. In non-ambulatory children, hip subluxation is very common, and hip dislocation, unfortunately, is also common. And so let's go over a case of a child with undiagnosed hip dysplasia. And this is an ambulatory child who is a GMFCS2 level, and unfortunately was seen at a very good institution that did not obtain a hip x-ray until very late, until the child was skeletally mature and had a flattened and deformed subluxated femoral head with hip pain and a very obvious limp. So this is a child who, if had been seen earlier, could have had a reconstructive surgery that would have dramatically changed the overall outcome of his hip. So in the early phases, the hip migration is less, and I'll describe the migration percentage in more detail, which is the percentage of the femoral head that is outside of the socket. And so in early hip dysplasia, you find less of a migration percentage, but more importantly, the femoral head is not irreversibly deformed. So you continue to have a round femoral head that can fit into the round socket. Whereas if you get a child late with hip dysplasia, it's much harder to reconstruct that hip, and any reconstruction that's done will not have as good of a response. Is pretty intuitive. So I think the debate is pretty much settled as far as ambulatory children. We must detect these hips early and treat them early so that the hip is normal because they're ambulatory, and the hip function is key to their overall function. But the debate in our orthopedic community for a long time has been, in the non-ambulatory children, does it really matter? These children are in a wheelchair, they're not using their hip, they can be positioned. Does it actually matter for these children or not? And I've trained at 2 institutions now, San Diego and Scottish Rite Hospital in Dallas, that probably up until about 5 years ago had dramatically different opinions about what ought to be done. The San Diego group was very proactive and has published that for a long time. And the Dallas group was relying on studies that showed that many of these children don't have pain later on. But as the better designed studies emerged, it became clear that even non-ambulatory children have a significant amount of hip pain and issues over time. And just a show of hands in the audience, how many of you have had non-ambulatory children with a hip dislocation with hip pain? And pretty much every hand in the room goes up. So if you're working with these children frequently, you see it frequently, which is why it has taken collaboration among those who see children with CP most frequently, that is you in the room, with those who are orthopedic surgeons that see them very infrequently, but at kind of key points, to come together to figure this out. So my wake-up call was a child early in my practice who was seen at an institution for some time and showed up to me at age 13, but at age 8 and age 9 had progressive hip dysplasia. You can see more and more of this hip going out between age 8 and age 9. Had maintained sitting balance, very little cartilage damage. If you were to look at that hip with an MRI, would have very little cartilage damage. And at this point, any hip reconstruction would have had a concentric hip with minimal to no pain possible over time. But unfortunately, a fairly reactive approach was taken. And by the time I met the patient, she had disturbed sitting balance, profound cartilage loss, as you can see from this intraoperative x-ray, and really at this point only a salvage surgery is possible. And the salvage surgeries are not very good in terms of pain relief. They're okay, but they don't take all of the pain away, and there's still limitations. And so I think there's pretty much broad consensus now, nationally and internationally, that even in the non-ambulatory children, and perhaps I should say especially in the non-ambulatory children, hip surveillance matters, because 20% of these children will develop a hip dislocation, which is a substantial burden on them as well as their caregivers. And 56% of these patients with hip dislocations will go on to pain. And as we get better with medicine and keeping more of these kids healthy in older life, their chances of having hip pain only goes up. Now, one of the challenges in describing these children and treating these children is that they have many medical comorbidities. And so a real ethical dilemma with the treatment of both hip dysplasia as well as scoliosis is, how can we assess whether the risks of surgery outweigh the benefits? And if you're going to take a proactive approach before any, there've been any symptoms, are you going to actually cause problems in these children? And I've highlighted all of the various problems that can occur in these children, and they're numerous. And really the crux of this argument and challenge is, how do you assess a child with disabilities? There's an adage that says if you've met one child with CP, you've met one child with CP, right? Which is that every child is very unique. And one of the challenges in some of the more severely involved children is communication really limits our ability to get primary outcome data from the children themselves. And so many of these health quality of life questionnaires are really not designed for children with CP. The CP Child questionnaire, developed by collaborators in Toronto, has been very effective and now has multiple studies that use it as the benchmark outcome instrument for describing the overall quality of life for children who are non-ambulatory and who have limited communication abilities. And it is not specifically designed for non-ambulatory, non-communicative children, but you can see immediately why it would be very applicable to that group. Because it takes the caregiver's perspective into consideration. And these caregivers need at least 6 months of experience with that person. And the questionnaire takes about 20 to 30 minutes to administer. And it's 37 questions based in 6 sections in all of the various domains that all of you work in every day, which is activities of daily living, personal care, positioning, transferring, and mobility, comfort and emotions, communication, social interaction, health, and finally, overall quality of life. And this questionnaire is very good at distinguishing between ambulatory and non-ambulatory children and has a very high reliability in the early studies. And as you can see from these diagrams, this CP child scorer correlates with hip displacement. And so now we have an outcome instrument to further bolster what we have seen clinically, which is that hip displacement changes the quality of life of non-ambulatory children. So you can see the overall score decreasing, as well as the health subscore. And probably one of the strongest correlations was actually between communication and social interaction. And that comes as no surprise for those of us who work in the functional domain, which is that if you have hip pain, it's harder to communicate, harder to get out into the world, and you're stuck in certain positions that make it very hard to have a productive and fulfilling life. So, early reconstruction and early intervention leads to better results in the non-ambulatory children. We have reconstructive options at the early ages, and as things go on, we really have only salvage options. So early treatment is better. Okay, let's go through the evidence for surveillance, and there's some high-quality evidence now, so we can feel pretty good about being evidence-based in our recommendations. And so the World Health Organization has described surveillance as the systematic collection, collation, and analysis of data, and the timely dissemination of that information to those who need to know so that appropriate action can be taken. And so this definition can really be broken down into 3 major points. It has to be systematic, that is, some type of evidence-based system needs to exist. It needs to be timely, in that early intervention is actually possible, and appropriate, in that early intervention actually improves the results. And so the goal of the rest of my talk is to show you the evidence that hip surveillance actually meets these World Health Organization criteria. So hip surveillance has 3 pillars. The first pillar is an assessment of risk. The second pillar is the threshold for treatment. And the final pillar is understanding the whole child. And so let's go through this first pillar, the assessment of risk. And the gross motor function classification system is our best way to assess risk in this category. I talked to you earlier about how there's a stepwise increase in how GMFCS level predicts the risk of hip displacement. But there's a special case, and it is the group 4 winter gauge Hicks classification patients with spastic diplegia. These are those who have pelvic retraction or pelvic rotation, hip flexion, hip adduction, hip internal rotation, knee flexion, and ankle equinus. And so here's a good example of a child who was also diagnosed relatively late with hip dysplasia, unfortunately, but has your classic group 4 pattern. And so these patients, although their GMFCS level is high, like this patient is a GMFCS level 2. In some situations, one might even consider him a GMFCS level 1. I mean, he's pretty high functioning, despite this very dense hemiplegic involvement. And so in most of the hip surveillance guidelines that you'll see, even if they're GMFCS level 1, the dense hemiplegic patients ought to be screened at a level that's closer to a GMFCS level 3. And so all of the hip surveillance guidelines really stratify the hip surveillance with GMFCS level 1s and 2s getting the least, The group 4 hemiplegic gait and GMFCS level 3 is getting kind of an intermediate level of frequency for hip x-rays and clinical exams. And finally, the GMFCS level 4s and 5s having the most. Okay, next, let's talk about the threshold for treatment. And that's with x-rays. Each of our conditions has a threshold for treatment. So blood pressure, diabetes, and neuromuscular hip dysplasia. So for initiating treatment with blood pressure, if you have a systolic blood pressure greater than 140, you start getting interventions. If you have a hemoglobin A1C greater than 6, you start getting interventions. And in neuromuscular hip dysplasia, if you have a migration percentage greater than 30, that's when you start having a higher level of scrutiny and perhaps with further displacement treatment. So the cornerstone to early identification of hip dysplasia is a relatively easy percentage or ratio. And it is the migration percentage, which is the percentage of the ball that is outside of the edge of the socket. Now, as you get into the details, defining what part of the ball to measure and what part of the socket to measure becomes a little more difficult. So in our third session today, I'll go over some details with you. And to obtain this, you need a single x-ray. It's important that it be an AP pelvis x-ray and not a hip x-ray. A hip x-ray defines only one hip, and so then 2 x-rays would need to be taken. And the dose of radiation for a child is actually paradoxically more for a hip x-ray than it is for an AP pelvis x-ray. So an AP pelvis x-ray is the one that you want. The radiation exposure is 60 milligrams, and in most facilities that frequently treat children, it'll probably be even lower than that because the radiosensitive areas are shielded and the radiation dose is brought even further down. To put that into perspective for you and the families that you interact with, the average annual radiation exposure for you here in Orange County is about 300 milligrams. As you go higher up to colder and more brutal climates, I'm just kidding, I have to say that just given that we're in Southern California, the radiation exposure goes up. So it's another reason to stay near the coasts. Okay. If you travel a lot, and if, let's say you're traveling to Asia, a trip from here to Tokyo and back is about the same exposure as a single AP pelvis x-ray. So it's about 0.5 milligrams per hour. So it's not negligible, but it is relatively low. And as you'll see from the guidelines, especially the care guidelines that the CP Academy has put out, there are options to reduce the frequency of x-rays. The ideal positioning for a child for this x-ray is for the supine AP pelvis is as follows. The child should be placed horizontally, and the pelvis should be horizontal and in line with the thorax. The legs should be coming down directly from the pelvis, so no adduction or abduction. And the patella should be pointing straight forward. This may require an assistant to hold the legs, okay? And so that ought to be emphasized with any radiology department that's doing this. And because of the frequency of foot deformities, the feet should not be used as a guideline. The feet can be anywhere. They may be in, they may be out. It doesn't matter. The patella should be pointing straight forward because we're really looking at the pelvis. As you know, many of these children have hip flexion contractures. And if you have a hip flexion contracture and you don't position the legs up on pillows, the pelvis will be forward, and I'll show you what that looks like, and then that makes it harder to interpret the x-ray. So the legs should be positioned on pillows to keep the pelvis pointing straight forward, accommodating for the hip flexion contracture that's present. So the ideal properly oriented AP pelvis x-ray should look like this, and this is actually a 3D CT that has been sort of masked to create the look of a pelvis x-ray. And then I rotated it to show you the differences that occur with rotation. So the larger image shows you, and this little box cues you, the blue box cues you in as to how it's rotated. So you'll notice that the iliac wings, or the pelvic wings, are relatively symmetric with each other. You don't see one on profile, one on the other. The obturator foramina down on the bottom of the pelvis are oval and are relatively of the same size as well. And the legs are not abducted or adducted. The femora comes straight down from the pelvis. The first image up on the right-hand side shows you when you rotate the image to the right, what happens. You get a profile of one pelvic wing and a sort of en face view of the other. And then the obturator foramina become asymmetric. And in this example, the legs are abducted as well. You can see that they're abducted. And when you tilt the pelvis anterior, you start to get what's called an inlet view of the pelvis. So you're actually looking at the pelvic inlet going out. And then the obturator foramina become like slits, so it's harder to interpret. And there's a lot more overlap of the femoral head with the acetabulum, so it becomes very hard to pick out the landmarks. So the critical migration percentage is 30%. So a third of the femoral head outside of the acetabulum. And in our third session, I'll go over with you the importance of which landmarks to pick for the acetabulum as well as the femoral head. And here is the very important critical piece of all of this, which is that unless specifically told to, an AP pelvis with a migration percentage of 30% will come back with a report like this from a radiologist. No evidence of subluxation or dislocation, no evidence of hip dysplasia, normal AP pelvis. And the critical thing here is to get quantitative. So there must be a quantitative measurement of hip migration percentage. Because if that is not done, this hip x-ray does look very good. But when you start measuring, you see that a third of the ossific nucleus is outside of the edge of the socket. And over time, in a higher GMFCS child, that AP pelvis will go on to subluxation and dislocation. So that's a very critical point. And even in Australia, where they've been pioneers of all of this, they have had difficulty with the actual measurement of migration percentage and are looking for innovative ways to make sure that that gets done properly. Because there's just enough time and difficulty in measuring this percentage that it's easy to just pass it off and come up with a qualitative assessment. But it's very important to get quantitative. The traditional calculation for migration percentage involves drawing the appropriate lines. And so there's a first horizontal line that is horizontally oriented to the pelvis using specific landmarks that I'll go over with you in the third talk. And then 3 perpendicular lines are drawn per hip that outline the edge of the socket and both the inside and outside borders of the femoral head to arrive at the final percentage. So as you can see, this is just inconvenient enough to make you not want to do it, right? It's not so inconvenient, but just inconvenient enough. There are options for those of you who have access to a fully functional templating suite on your x-ray in your office, which really only applies to people who work at large academic centers where orthopedic surgeons have asked their radiology department to load these templating suites onto their systems. And they are very convenient. They allow you to have a tool that adjusts and it comes kind of automatically pre-populated. You can move the various tool portions and arrive at a very accurate and easy to read migration percentage that then can be loaded into your system for further evaluation over time. So we're fortunate to have this at our institution, but we recognize that that's not freely available everywhere. So to address that need, we developed this freely available app that I'll show you how to use in our third session that has other features in addition to this migration percentage ruler that allows you to take a photo of an x-ray, whether it be on a screen, on a piece of paper, even a sketch, no, I'm just kidding about the sketch, yeah. And take a picture of it, and it's not stored on your device unless you want it to be stored. And within the app, it's automatically deleted, so there's no real worry about privacy, although we do encourage you to not take photos of patient-protected information or health-protected information. And then you can actually zoom, rotate, and use a tool on there to quickly arrive at the migration percentage. And we found in our early studies that it's as fast as the fully functional system that you have to pay for, and as accurate. So, and it's free. That's nice. Okay, so the final pillar of hip surveillance is your physical exam or overall assessment of the child, and that's what you'd be doing. And so these are critical questions. Is the child having hip pain or worsening function? Is their GMFCS function changing? Has there been a change in the hip range of motion? Are there any high-risk issues that I talked about before? So all of these would happen on regular exams. So all of that together constitutes a hip surveillance program. The assessment of risk with each session, the stratified x-rays for identifying silent hip dysplasia, and finally these regular physical exams. So there are 4 major systems and many others that have been locally developed. I just highlighted 4 here of hip surveillance guidelines. And these are guidelines that are really consensus guidelines. And the strongest evidence has come from Sweden and Australia that have, we've been fortunate enough for them to be very systematic as they've rolled out these guidelines to actually collect data and then report it to us. And so without those reports, we would have been nowhere. So that's a plug for all of us collaborating as we roll this out to collect data and interpret it, because our medical system and our medical environment where we practice is very different from these other systems that have come along. I mean, we are looking at partnerships in a health system that's not really a system, you know, versus a centralized medical system like the 3 at the top of this list. So if you go through each of these guidelines, Sweden initiated it in 1994, and they had regular exams and x-rays that were stratified by GMFCS level. So they identified GMFCS as a very important tool very early on, and we're very fortunate and indebted to them for doing that. In Australia in 97, and then their revision in 2014, they recognized that there was a group of children who had dense hemiplegia who were developing hip dysplasia at a higher rate than their GMFCS level would have predicted. And so they introduced higher level frequency surveillance for that group. They also introduced a caveat recognizing that they wanted to decrease the amount of radiation exposure to tell you when to reduce the frequency of x-rays given stability of the x-rays themselves. British Columbia did a really good job of synthesizing the information, and then recently at the CP Academy, they won an award for a multimedia award for the instructional material that they've put online on their website that I really encourage you to look for, that has videos, and it's really aimed at a therapist and medical professional level. So it's very, very appropriate for this group. And then literally, you know, weeks before this presentation, the CP Academy released their care pathway that probably should become our way of doing hip surveillance, because it's been sort of stamped by the national societies, and I think over time it will be stamped by the Pediatric Society of North America and others, and hopefully even the American Academy of Pediatrics, and it will become a consensus that all of us in the States can, and in Canada as well, can rely on as at least a baseline for how we communicate. And I'll go over the care pathway a little bit in more detail, maybe in sort of a question-answer session, because I think that might be the most appropriate way to go over it. But it mirrors very closely the Australian guidelines in that it has GMFCS stratified surveillance. It has the Winter Gauge Hicks 4 group as requiring increased surveillance, and it also gives you an opportunity to reduce the amount of surveillance if the hips have stabilized. And it actually goes a little further than the Australian group and the British Columbia group in reducing the amount of hip x-rays. So I think that's a positive development, recognizing that you have to stratify risk with the risk of actual exposure to radiation. So the evidence is pretty strong, and I would say there are a few medical studies that have sort of spurred me to action. I'd say very few. Most of them are pretty dry, and I forget them. And they apply to a very small percentage of what I do, right? I mean, really. But this study out of Sweden, it was amazing, because the first the first word in this study blew me away, which is prevention. Because up until the publication of this study, I was under the assumption that you had to be reactive. And actually, in further digesting this study, I would argue too that prevention ought not to be the only goal, because there are some patients, some children, who are too medically fragile for the intervention, and so it should not be seen as a failure if you have children who have dislocations. I'm just putting that out there. But in Sweden, which I'd like to just let you know is less than the population of LA County. Actually, that may not be true, but at least less than the population of Southern California, for sure. It's 9.8 million, which is less than the population in Northern California. So we have a task on our hands in California to apply this more broadly. Let me just put it that way. So their 20-year results, what did they show? They found that before surveillance, they had not a lot of people really in tune with the disease, so to speak, because the rates of salvage surgery were relatively high, and they were doing very little reconstructive or preventative surgery. So they had a reactive approach. The kid has pain, they do the surgery. In the first 10 years, they eliminated salvage surgery, but increased the amount of preventative and reconstructive surgeries that were done. And that trend continued in the years 10 to 20. And so one could ask the question, well, is this just surgeons getting busier? But you can see here that this early intervention decreased the percentage that had hip dislocation over those 20 years. So by 10 years, that had reduced to between 1% and 2% of the population, and by 20 years, they had completely eliminated dislocation in their population. Australia found a very similar a similar sequence of events. Their hip surveillance clinic, HSC, found they had increased number of preventative surgeries over time. Very nice to see also a decreased number of reconstructive surgeries over time. And so the preventative surgeries were actually working to reduce the number of reconstructive surgeries across the population. And the rate of salvage surgery decreased down substantially over that time period as well. So we owe a debt of gratitude to Australia and Sweden for showing us that a hip surveillance program should be considered the standard of care for kids with CP. And so when we go back to the World Health Organization definition, we really see that hip surveillance really is a true surveillance program in that it can be systematic, it can be timely, and that these timely interventions actually reduce the burden of disease and improve the outcomes. So just to review, we can be systematic with our application of GMFCS. We can use any of these guidelines, but here in America, I think we ought to seriously consider banding together and all using the CP Academy guidelines, and that the timely information with hip migration percentage as our guide, as well as the child's functional level, can allow us to do more preventative surgeries and maybe fewer reconstructive surgeries, and hopefully very little, if any, salvage surgeries. And that can substantially improve the results over time, and we may see similar results in California. So finally, how do we apply this in California? And that's a real question that I've been wrestling with. There's a lot of local interest in each of the groups. I'm happy to see some of the local groups cross-pollinating here between Riverside and Orange County. In Northern California as well, we're kind of locally doing things, but really for us to have something to say at the end of 20 years that we've done something better and to really further the knowledge of care, we have a golden opportunity here through our connection through California Children's Services to really further the care of these kids. Our population is very large compared to the other studies. It's bigger than Australia. It's more than 3 times the size of Sweden. And now we have the numbered letter that really gives us charge and has established the standard of care across the state. So finally, I'd like to just quickly go over this website and app that we've developed and some of the features of the app, and then I'll go into more of the details in our third session. In 2016, we were really honored to get these 2 awards for this app through the CPE Academy. And the website is going to be updated with more and more information regarding hip surveillance and maybe even some of these videos. So the first aspect of the app is the educational component. And so a lot of the details that I've gone through here in my talk are there on the app itself in terms of organized by PDFs. So we have PDFs on why hip surveillance is important, how to interpret an AP pelvis X-ray. There's a positioning protocol that can be downloaded from the app and then printed out and given to any radiology department. It's the same protocol that is in the CCS numbered letter. There's also a description of all of the GMFCS levels for those who aren't as familiar with describing gross motor function classification. And then the hip surveillance guidelines from Australia, Sweden, as well as the one that we developed for the app that was kind of a combination of those, as well as the British Columbia, are all on the app. And we intend to include the CP Academy care pathway over time in that as well. There's a guideline schedule tool that allows you to just sort of touch the child's GMFCS level, and then it will also prompt you as to whether the child has a winter gauge Hicks 4 or not for the GMFCS 1s and 2s, and then gives you the recommendation. These recommendations haven't been updated yet to the CP Academy recommendations, but they will. Finally, the tool we'll go over in our third session. So hip surveillance in California will likely be a combination of local empowerment through education and outreach programs like this, a partnership between all of our institutions to make sure that the children aren't dropped between institutions. And finally, I'd like to emphasize the importance of data collection and evidence-based intervention over time. So I'm very eager to start the conversation on how we do all of this, and free to take any questions now this time. So thank you so much.